be able to diagnose it, and then know how to manage patients that present with bradycardia, because we get to see these cases and we need to know what to do about it. And so we're having this discussion under the following outline. We're talking briefly about introduction, epidemiology. We want to know how the anatomy and how impulse is being generated in the heart. Talk about the pathophysiology, the clinical features, and how to manage these patients. So starting off with the case presentation, Dr. Chima.
Okay, so this is a patient of our facility in Cardiologist Specialty Hospital. His name is Mr. PD, so 74-year-old, known hypertensive. Actually came into the hospital on account of recurrent dizziness. He complained of having this recurrent dizziness, and he noted that it was worse while he walks and also while standing. Actually, with those dizziness, we had also complained of a bit of lightheadedness. There was no history of any fainting spells of consciousness. There was no difficulty breathing, no palpitations, chest pain, or leg swelling. So, like I mentioned before, he was a known hypertensive. He was actually on his antihypertensives and made pain about Satan. And when we examined him, we noted that his pulse rate was significantly low, 2 beats per minute. While his blood pressure was slightly elevated, 148 to 198 millimeters of mercury. So this case presentation will be able to give us some guidance on how we evaluate our patients with bradycardia.
So how do we go about evaluating cases like this? Because we get to see them, people present with low pulses. So what is bradycardia? Bradycardia can be defined as when your heart rate is less than 50 to 60 beats per minute. Some will say less than 60, but the American Association Cardiac College, the American College of Cardiology have said that once it's less than 50 beats per minute, we can now say this patient has bradycardia. But generally, anything less than 50 to 60 beats per minute is said to be bradycardia. But we should also know that in some individuals, this is like a normal findings for them. It's not always a pathology. Like in people that are athletes, we get to see things like this in them. And then as a normal aging process, we get to see that some people's pulses get to reduce a bit. It may also reflect significant disease in the sinus node, either the sinus node or the atrioventricular node or the His-Purkinje conduction system. We'll get to see all that when we talk about the anatomy. And bradycardia, what some of the things we want to look out for when a patient has bradycardia is that it could either be as a result of an intrinsic factor, that is something that has to do with generation of impulse, either from the sinoatrial node or the AV node, and generating those impulses. Or it could be an external stimulus that is affecting it. It could be an extrinsic factor. And assessment of symptoms is a critical component in the evaluation and management of bradycardia. So apart from them presenting with low pulse, we need to know what they present with symptom-wise, because that's what will guide our management. And then pacemaker plays a major role because it's highly effective in cases where they present with symptoms. And treatment is not solely based on, oh, this patient presents with a low pulse. It's looking at the patient as a whole, depending on if the patient has symptoms or not. So it's important to discuss the epidemiology so that we'll see how frequent these cases can be.
So a bit of the epidemiology of bradycardia. In common etiology for bradycardia is what we mentioned as sinus node dysfunction. It's quite a very, very common cause. And it has been noted that it occurs in 1 in 600 patients that are above 65 years old. And actually, it accounts for more than 50% of pacemaker implantation in the US. And like my Dr. Inuwa mentioned earlier, sinus bradycardia is quite common in elderly. Those are the extremes of life, and young people to young athletes, people that engage in sports, basketball, football. When we check their pulse rate, we know that the pulse rate is usually low, and it's sinus bradycardia. So most bradycardias usually, most bradycardias occurring in elderly people usually require cardiac pacing. The pacemakers being most commonly, more than 80% of pacemakers are typically implanted in those that are above the age of 65. So there was a research done in Ethiopia and Africa here. The cross-sectional study showed that at least 25.4% out of 634 adults above 40 years had sinus bradycardia.
So going through the anatomy, because it's important to know how these impulses are generated so that we understand the pathophysiology of all this. So we have what is called the sinus node, and it's a collection of specialized cells, and it's in the right atrium, and it's being supplied by the right coronary artery majorly. And then we have, in some cases, some is being supplied by the circumflex artery, that's from the left coronary artery. And then normally impulse originates from this sinus node down to the AV node, and then it goes through the bundle of His to the different left and right bundles. So talking about the AV node, we also have it arises, it's been supplied by the atrioventricular nodal artery, which comes from the posterior ascending artery, which is also a branch from the right coronary artery. And all this is important because in cases where we have inferior myocardial infarction, we know that the right coronary artery is the one that actually supplies this area, and if it's affected, that's why we have issues with SA conduction and AV load, and they could present with a low pulse in such situations. And then when these impulses are generated to the AV node, it goes, as I said, through the bundle of His to the right and left bundle branch. And then it's being supplied by both the parasympathetic and the sympathetic. For the parasympathetic conduction, it helps to decrease the sinus node automaticity. So anything that would affect the parasympathetic tone, it would reduce firing from the SA node, and patient could present with low pulse. And anything that would increase sympathetic overdrive would also increase the pulse. So this is a diagram that shows us, just shows us what we just explained now, that from the sinus node, there's activation down to the AV node, and then the bundle of His, then dividing to the two branches, and that's how the heart is being activated. So we need to know the different causes of this bradycardia, because these are the things we have to look out for when this patient presents, because it's important to know the etiology, because that will guide us in how to manage them.
So for causes of bradycardia, we can just broadly classify them into intrinsic causes that occur as a result of affectation of the sinus node and AV node, or extrinsic causes, things outside of the heart conducting system. So common intrinsic causes of bradycardia, we have the sick sinus syndrome, which we'll still elaborate on as we progress. Conduction system disease, any illness that affects the conducting system, that's from the AV node down to the bundle of His from the SA node. Then coronary artery disease, like Dr. Inuwa mentioned during the anatomic presentation, the right coronary artery branches supply the SA node and AV node. So, and if there's any blockage, any coronary artery disease can affect those supply and also affect the AV node, leading to bradycardia. Cardiomyopathies, infiltrative disorders, which can infiltrate and affect the connective systems. Collagen vascular diseases, inflammatory diseases, or surgical traumas. This is an intrinsic cause of bradycardia.
Especially during procedures when you're doing an open heart surgery or any of those interventions, one has to be careful because any form of surgical trauma to the SA node or the AV node can trigger all this.
Then for extrinsic causes, drugs are very, very common.
Yes, very common, because a lot of our patients, heart failure patients, hypertensive patients, they're on all these medications. We talk of the beta blockers, the calcium channel blockers, digoxin, amiodarone. There are a lot of patients on these medications due to whatever condition they're managing. And we need to ask them about their drug history, because this might just be the only cause of the bradycardia they are having, which should be adjusted or stopped if needed.
And we also have autonomic influences, like we mentioned before, parasympathetic innervations to the SA node and AV node causes reduction in the firing of the SA node, while sympathetic does the opposite. So anything that affects the autonomic system invariably cause, especially the parasympathetic, if it's a parasympathetic overdrive, can lead to bradycardia. Then electrolyte disturbances, that's why it's quite important when we're evaluating our patients to check our electrolyte, because they're common causes. Hypothyroidism, so endocrine illnesses too could lead to bradycardia. Also, our stroke patients with raised intracranial pressure.
So we talk of the Cushing's reflex. Exactly. Bradycardia is one of the things we see in them.
Cushing's reflex. Yes. Then hypothermia too is a very common cause, especially in temperate regions in the US and abroad, when the weather is quite cool, it actually lead to bradycardia. Then sepsis too, and we mentioned athletic hearts, people that engage in vigorous physical activity regularly, we tend to have bradycardia.
So this could just even be their baseline pulse. It's not like there's anything wrong with them, but most importantly, they won't have symptoms. All you just notice is that they have a low pulse. They could just be ranging between 50 something, and that is just their stable pulse for them based on the fact that they're into, you know, sports and all that. So that's why we said we need to look at this patient holistically. It's not just saying, oh, the pulse is low. We need to look out for these causes, because when collecting or taking history, we need to take history around all these causes to see if there is a cause. Because once you are able to reverse those ones that are reversible, then the bradycardia would improve.
And symptoms also improve. So this is another slide just to buttress on what we have previously talked about. Conditions that are associated with bradycardia, autonomic dysfunction, which is quite important. You have a neuro-mediated syncope, situational syncope, and cardiomyopathies, any ischemic or non-ischemic cardiomyopathy could invariably lead to bradycardia or infiltrated diseases. Talk about psychosis could lead to bradycardia. So let's just move on to the pathophysiology.
So going to the pathophysiological history of bradycardia quickly, we should have it at the back of our minds that most of the issues has to do with either the SA node or the AV node. And then for when we talk of this SA node, we are talking of sinus node dysfunction, also known as sick sinus syndrome. What happens is that there's a disordered automaticity, or you have impaired conduction from the sinus node. And at times you get to see this in the elderly people where you have fibrous formation, the sinus node, and all this with impaired conduction from the SA node. And then AV conduction disturbances can result into impaired conduction in the AV node, and that's when we have all the AV blocks we'll talk about later on. And we've talked about that it could be due to an intrinsic pathology, or it could be extrinsic causes. So even with sinus node dysfunction, it could be things that has to do with destruction of the sinus node itself due to fibrous tissue formation in the SA node, and as such, it's there's reduced firing from the SA node, you know, and that will cause the patient to present with bradycardia. And since the sinus node is a complex cell in the atrial wall, most often permanent injury is not always from infarction or infection. It's quite uncommon as compared to the AV node. So when we have sick sinus syndrome, most of the time it's always as a result of fibrous tissue, intrinsic issues going on. Then for the extrinsic issues for sinus node dysfunction, we've mentioned already the medications these patients could be on. We've talked about the electrolyte imbalance already. And then we've talked about increased intracranial pressure. So when we talk of sick sinus syndrome, sinus node dysfunction, they could also present with bradycardia tachycardia syndrome, known as bradytachy syndrome, where they are having bradycardia at some point, and then after a while they're having tachycardia. We'll show you some. We'll show you an example of that. And then there's also decreased SA node automaticity. That's when they have sinus bradycardia. So there's reduced generation of impulse from the SA node, and it's reduced even though it's in a sinus pattern. Or it could just be failure of formation or conduction of these impulses from the SA node, like when you have sinus pulses or sinus arrest, when the pulse, there's a delay of generation of impulse of greater than, there's a pulse for greater than 3 seconds. You know, so these are ECG. The first one is showing us a sinus pulse of greater than 3 seconds. If we calculate the distance between the third complex, that's the, okay, and then the third complex, third QRS complex, and then the fourth one, we can see there's a long pulse. And when we calculate it and it's more than 3 seconds, when we know that one big box on the ECG is 0.2 seconds. So by the time we calculate that it's more than 3 seconds, we're already thinking of a sinus arrest. But the second one shows us a tachycardia syndrome, where you can see tachycardia going on initially. The heart rate is about 150 beats per minute. And then after a while, there's a long pulse, and then it picks up again and starts with tachycardia. So all this, when you see that on the ECG, we're thinking of a sinus node dysfunction. So we've talked about sinus bradycardia, saying sinus bradycardia, or sinus pulse, or tachycardia syndrome. Okay. Then when we think of the AV conduction, because we talked about bradycardia we've talked about bradycardia. Could either be from, the issue could be from the SC node or the AV node. So for the AV conduction, there could be a delay from the AV conduction down to the bundle of ease, and delays exclusively below the bifurcation of bundle of ease is what will then lead to bundle branch blocks or fascicular blocks, depending on what's presenting. And then AV conduction can also be influenced by intrinsic or extrinsic factors, as we said, as the SA node 2. But the difference here in the AV conduction, we talked about infarction and infection could be more seen in AV conduction, and then trauma and catheter trauma because of procedures being done, open heart surgeries or interventions, because if there's any trauma to the region of where the AV node is, you could have AV conduction disturbances. So these AV conduction disturbances, we need to look out for them. That's why ECG is so important in this case, is because we have to look out for the AV blocks. And there are 3 types. We have the first degree, second degree, and the third degree AV block. So going through the first degree AV block.
Okay, so for the first degree AV block, usually results as when the PR interval is actually prolonged. And the PR interval usually reflects conduction time, as conduction of impulses from where it's generated in the SA.
Yes, from the atrium down to the ventricle. Yeah, so it passes through the AV node. So if there's any form of delay there, then you have that means there's a block in the AV node. And so when we talk of first degree AV block, it's very important because the management of these different blocks differ. So we need to pick it when we see it on ECG. So normally the expected PR interval should be less than 0.2 seconds. That's the 5 small boxes or 1 big box. But once you're having a PR interval that is more than that, consistently, meaning if your PR interval is 0.24 seconds, for example, consistently, you just see 0.24 seconds, 0.24 seconds consistently throughout that reading strip, then you have a first degree AV block. Then the other type is the second degree AV block, where you have the type 1 and type 2. So it's Mobis type 1, Mobis type 2. So for the type 1, what happens is that there's an increasing PR interval. So if the first PR interval is 0.24, the next one might be 0.28, it's increasing, and then all of a sudden, there's a misbit. So you see a P wave that is not conducted, so you don't see a QRS. And then for the type 2 block, what happens is that the PR interval is just regular, and then there's just a block. I hope we can all appreciate what we can see on the ECG. So you can see the PR interval. Let's start from this first QRS complex. You can see the PR interval. It's just regular. Everything seems smooth, and then there's just a P wave with no QRS conduction. Because this is very important, because at this stage, this patient will now need a pacemaker. The other one, that's for the type the AV block, type 1, the first degree, and then the Mobis type 1, you don't need a pacemaker. So it's important to be able to pick this. So when we pick patients like this, regardless of symptoms, they need a pacemaker. And the reason for this is this would gradually can become a third degree after a while, and that's a complete block. When you now have a dissociation of the atrium and the ventricle
activities, they're beating independently of each other.
So we can appreciate that. You can see P waves coming up. The PP interval is same, the QRS interval is same, but they are not, there's no relationship. The P is coming up when it feels like coming up. The P wave is not necessarily conducting, so to bring up the QRS complex. So there's a dissociation. That's a third degree heart block, and this is important to pick, because in this individual, the person will now need a pacemaker regardless of symptoms, even though they could also present with symptoms. But without symptoms, we see this patient will benefit from a pacemaker. So moving on, it's good we pick up these clinical features in them.
Yes, clinical features are quite important. And like we mentioned earlier, there are some patients that might be asymptomatic, they don't have any symptoms. And like we said, athletes, for example, who participate in vigorous physical activity, they have bradycardia, sinus bradycardia, and they don't typically present with symptoms. But for people that present with symptoms, the typical symptoms we see in them, like our case presentation showed, and they might present with dizziness, which is quite common. They might present with syncope, that syncopal episode, you just heard that someone collapsed, It's quite important. That's why when the patient presents with syncope, it's very, very important to request for an ECG. Or pre-syncope, as the patient is feeling a little bit lightheaded, feeling like he wants to collapse. So those are very, very important clinical features of patients with bradycardia. And also they may present with fatigue because of the heart rate is quite low, so the ability of the heart to pump blood to meet metabolic activity is reduced. So it might always be fatigue, complaining of tiredness. So things like this, even if it might be non-specific, it's always very, very important to request for ECG to pinpoint. The effort intolerance too, quite similar to fatigue in the mechanism and physiology of which it happens. And it might also present with dyspnea on exertion because the heart is not pumping blood as adequately to meet up the demands of the body. So they have this breathlessness when they exert themselves. And heart failure symptoms, easy fatigability, effort intolerance, I've mentioned those ones. Then confusion is quite important because as a result of cerebral hyperperfusion, the heart is not pumping blood to meet up the brain metabolic demands. The patient might be confused. So these are common clinical features we see in patients with.
Then just to add to that, so for the asymptomatic ones, we need to be careful too in asking them this history, because the caveat there is some of them, because they are elderly, they actually don't do any activity. So when you ask them any difficulty in breathing or easy fatigability or distant exertion, because they're not exerting themselves, they'll say, oh, none. But if they actually do move around, they become breathless, So it's always important to actually ask them that, because some of them are elderly and they really don't do much.
Okay, so this was the case presentation that we did earlier when we started the presentation. This was the patient that presented with recurrent dizziness and lightheadedness.
Presented to our hospital. So this is a live case.
This is the ECG of the patient, and you can see from the ECG of this patient, you can see the space in between the RR intervals. You can see how many boxes from the ECG. So this patient is obviously bradycardic. And looking at the ECG, we're able to tell that this heart block is a complete heart block. I can just mention.
Okay, I don't know if you can appreciate the P waves. You can see some little bumps coming up.
And they're quite regular.
So if we look at them, we can see some are even on the T waves. The T wave is the wave just after the QRS complex. But if we look at those bumps, in the those are the P waves. The P to P are regular, the QRS are regular, but there's no conduction from the P to the QRS. You can see the P waves, they are coming up on their own.
You can see this one, you can see this coming up independently of each other. There's no QRS complex following the P waves. So
this is a case of a complete heart block. This is a case, the patient that presented.
So typically we want to, after taking our history and trying to find out the etiology, and also examine the patient to find out possible secondary causes. We also want to investigate patients with bradycardia. These are the typical things that we want to ask for. The resting ECG.
First of all, that would pinch down the diagnosis of sinus bradycardia. So we need to be able to read our ECGs properly to know that, oh, this patient has bradycardia, and then is there more to the bradycardia? Is it a sinus bradycardia where you have a regular upright P waves before the QRS complex? Or is it the different AV
blocks
we've talked about? So we need to even look out at the ECG and be able to pick it, first of all, that, okay, yes, there's bradycardia, what type are we dealing with?
Also want to do a Holter ECG. The Holter ECG is the one that we put on the patient.
And it's readily available,
in our facility,
24 hours, 48 hours, depending on the patient's symptoms. And there's some things that you might not readily pick on the resting ECG. There are cases where you pick a resting ECG of what seems like a sinus bradycardia, but by the time you do the Holter ECG that takes the rhythm of the individual for 24, 48 hours, we'll find out that down the line, not just a sinus bradycardia, the patient has some other AV conduction issues going on, or a sinus node dysfunction where you can see a tachycardia syndrome or a pulse and all that, or an arrest, a sinus arrest. So that Holter ECG actually helps to give us a clear idea on what's going on with the individual.
We also want to ask for our regular electrolyte urine creatinine. As we mentioned, etiology, electrolyte derangement is a very, very common cause of bradycardia. So we also want to do that. We also want to do our calcium levels, our magnesium levels, because derangement in these electrolytes could typically lead to bradycardia. Also, the thyroid function test is typically indicated because I mentioned the hypothyroidism is a cause of sinus bradycardia. And also, we want to do the glucose level, hypoglycemia too, could be a cause of bradycardia. Then for selected cases, depending on case history, there are some certain things we want to do. I might want to take a toxicology screen, for example.
Especially if the patient is already on
digoxin, for
or
example,
on any other medications.
It's a very, very common cause. Patients, our heart failure patients, some of them are using digoxin.
Yes.
So it can typically cause bradycardia.
So when we can check the levels, it's good to check to know if it's as a result of digoxin toxicity that is ongoing. And also troponin levels. You mentioned that the patient could be having a myocardial infarction, you know. That could be the presentation, so you might pick on ECG, and the person is presenting with bradycardia. So your troponins are quite important. You know, we talked about the anatomy, how the right coronary supplies both the SA node and the AV node majorly and all that.
So when that conduction system is impaired, it can lead to bradycardia. So coronary angiography is very, very important. Then the last but not the least, electrophysiology studies.
Okay. So talking about the ECG, we can see that this is what a sinus bradycardia looks like. We can see that you have P waves coming at the exact time prior to the QRS complex. So your PR interval is regular, and there's an upright P wave in lead 2. You know, you can see an upright normal morphology P wave just preceding your QRS complex. And then when you count your heart rate, that's the RR interval, this should be about 50 beats per minute. So we're already dealing with a sinus. 4, 5, 6. So you're already dealing with a sinus bradycardia here. Sorry, we're dealing with a sinus bradycardia here. So it's important to be able to pick it. And so in this kind of patient, we want to know what kind of symptoms the person is presenting with to know what next to do.
So for our case presentation, following evaluation, when patient was adequately evaluated, patient then had a dual chamber pacemaker installed. It was an awake procedure. Patient was completed in 45 minutes, and he had a repeat ECG following the procedure. He was stable, and we discharged him.
And he did very well.
Very well.
And he still comes to the clinic for follow-up, yes. And we get to interrogate the pacemaker when there's a need or 6 monthly.
And he's still currently being followed up.
Yes, and his heart rate has picked up. He doesn't have any symptoms anymore. So all those symptoms he presented with, all that has resolved.
Yeah, just by implantation of this dual chamber pacemaker that I'm talking about. So this is ECG following the procedure.
Okay. So talking about managing this patient, when they present, what symptoms do they have and to what severity? You know, what's the degree of these symptoms? And then we need to confirm the bradycardia, as we said, and then look out for those reversible causes, yes. Especially those electrolytes that would readily see all the hypokalemias and all the rest that we can actually treat that would actually reverse the bradycardia. So, sorry. Okay, so moving on, sorry. So after the, so in assessing this patients, we want to know, okay, this is the ECG that also, I don't know, I hope we can appreciate this better. This is also a patient that presented in our facility. We can appreciate the P waves that are coming up. Maybe look at lead 2, or we can look at V1, the last rhythm strip down, and then we can appreciate the P waves coming up just before the QRS, but there's no conduction. So the P waves comes up whenever it feels like, but the P2P is regular, the QRS is regular, but there's a dissociation. It doesn't follow the usual pattern like what we saw with the sinus bradycardia, where we saw a P wave coming at a particular time prior to the QRS complex. So drug treatments, normally for patients with bradycardia, we don't get to treat those that are asymptomatic, you know. So when they present, that's why we talked about the symptoms, you know, that's why we talked about the symptoms. We don't need to give medications for those that are asymptomatic, you know, although I would explain later on those ones that are asymptomatic, but they might not, they would then need a pacemaker. Or as we talked about the electrolytes, that's what we need to investigate this patient. We need to correct the electrolytes and then address all the etiologies, because you have to think of whatever might be causing it in that individual, because it could be secondary to all those intrinsic and extrinsic causes we discussed. And then there's room for IV atropine. We'll discuss it further. And then at the time when they present in the emergency, there will be need for a temporary, can do a temporary pacemaker at that point before we now take a decision on the permanent pacemaker. So we'll talk about that. But going through the ACLS bradycardia algorithm. Okay, going through the ACLS bradycardia algorithm, it's necessary to know that this patient could just present in the emergency. And when they present in the emergency, you know, we need to decide on what to do. Is it, at least we can check our normal vital signs and then know what the pulse is in examining, when you examine the patient, just taking a quick history to just get any information that's of importance at that time. Later on, we can get more detailed history, and then we check the vitals. We now, if we find out now that the pulse is less than 50, you now want to identify other causes, but make sure you're resuscitating. You know, you want to ensure that the airway is patent, the patient is breathing well, you know, there's good circulation, oxygen support, you know, and all of that. And then immediately you place your 12-lead ECG and check the rhythm so that we will know what we're dealing with. You know, the patient will present with hypertension. We just follow this algorithm to know what next to do. Because if the patient is hypertensive, or the patient is confused, you know, or the patient is presenting in heart failure symptoms, we need to assess all of that. And then if this, and of course, when they present with all of that, that shows that this is symptomatic bradycardia, because not just a pulse that is low, they are having symptoms, you know. And then there's room for giving IV atropine. You do 1 milligram every 3 to 5 minutes, and then the max you can do is 3 milligram. And if you're not getting any improvements in the pulse, then you would then have to either use transcutaneous pacing, which is available here. We get to do this transcutaneous pacing, or we can step up the IV instead of just the atropine. Since it's not giving us the effects we need, we can then do dopamine or epinephrine in that. We just follow the algorithm, and then subsequently we then consider transvenous pacing. We'll talk briefly about that later on. So, moving on. Okay. So there are other medications, as we said, because the ECG would guide us on what next to do. So we've talked about the use of atropine, and if we're not getting enough response, as in the pulse isn't increasing and all the rest, there's room for dopamine, and there's also room for epinephrine. And if you are dealing, because that's why we need to know the history of this patient, because what if it's that the patient had an overdose of a calcium channel blocker, because they are on these medications, we're talking of the elderly people, you know, so we never can tell if it's as a result of drug overdose, you know, and we can get the antidote of that drug, then it's necessary to correct that, because if you're correcting the antidotes, then if you are correcting the drug overdose with the antidotes, then the effects of the bradycardia would be reversed. So if it's as a result of a beta blocker overdose and all that, there's room for glucagon and room for insulin therapy also. And then calcium channel, calcium gluconate, if it's as a result of calcium channel blocker overdose. And if it's as a result of digoxin overdose that is causing the bradycardia. That's why I kept saying it's important to look out for the cause. You know, there's digoxin antidote, which is the digoxin antibody fragments that can be given. So what are the indications of permanent pacemaker? So we've talked about how this patient can present, because sometimes they could present in the clinic. You know, that gives us room to do all the, we can do all the investigations we need to do. They check the electrolytes, as we mentioned, and look out for the causes. But what we just went through, this algorithm we went through, was for those that present in the emergency. What can we do immediately as they present with the symptoms and pulse rate less than 50? We've talked about giving atropine. If the atropine is not increasing the pulse rate, we talked about dopamine or epinephrine, and then we need to refer and move forward and do and put either a transcutaneous pacemaker, pending when a permanent or a transvenous pacemaker can be inserted, while we're trying to find out the etiology and treat. So what are the indications of permanent pacemaker? I'm sorry, we can't move this, okay. So the indications for permanent pacemaker, because we need to know when to refer this patient to get a permanent pacemaker done. Because as we said, apart from those that present in emergency, you have those that are very stable that come to the clinic. We need to know when they need a permanent pacemaker. And these are the recommendations. Class 1 recommendation is that they should have a pacemaker. Class 2 is that you should consider using a pacemaker for them. So for those that we talked about that have symptomatic sinus node dysfunction, it's important that it's symptomatic. So we mentioned all the sinus node dysfunction. We talked of tachycardia syndrome, sinus arrest, sinus bradycardia. If they are symptomatic, then they need a pacemaker. Then we've talked already about the AV conduction abnormalities, the 3rd degree AV block, and then the 2nd degree Morbis type 2. Regardless of symptoms, they need a pacemaker. And then for people that have atrial fibrillation with bradycardia, that means they have a slow ventricular response, they also need pacemaker. Then for those you can consider based on whatever you're checking the risk-benefit ratio in them, those with symptomatic chronotropic incompetence, those that have symptomatic 1st degree AV block, because we already said that if it's a 1st degree AV block, this person doesn't need a pacemaker. But when they're symptomatic, at that point you should consider it, And then when you're dealing with syncope of unknown origin, you're not sure of what's causing it and all of that, especially provoked during an electrophysiologic study, then you should consider a pacemaker. So what's this pacemaker thing we've been talking about? It's an electronic device,
Because an electronic device is typically the size of a pocket watch, as small as that, and it usually senses the heart rhythm. You implant it usually on the left shoulder region. It senses the heart rhythms and it can be able to provide electrical stimulation when indicated. Like I was mentioning earlier, there are 2 types. Either I have the temporary or permanent type of pacemaker.
And most of the time, the temporary ones is what we use in the emergency setting while we are still trying to sort out the reversible causes. You're just trying to keep the patient alive. Depending when you sort out other the reversible causes, or you're planning for a permanent pacemaker. So when you talk of temporary pacing, you either have the transcutaneous or the transvenous. For the transcutaneous, is like what we just like it comes like the AED, the automated external defibrillator. It has 2 parts. You put one on the anterior surface and the other one posteriorly, or we'll show you a diagram of how you can put it, or anterolateral location. So it's supposed to help pace the heart temporarily. So you're putting it transcutaneous, just on the skin. And then transvenous, you're going through the vein. And most of the time that's used during heart surgery, because at that point in time, based on what they're doing in the heart, you might need to take control of the pacing of the heart at that point in time. And then once the cardiac surgery is over, it might be removed. So it's just a temporary measure. And then this is what the pacemaker looks like. You can see the pacemaker battery and then the leads that is then inserted in. Then we also have the permanent pacemaker, which could also be transvenous too. We go through like what we did for our patients.
Yes.
We just put it subcutaneously. We put the generator, that's the battery subcutaneously, and then we pass the leads in. And then there's also the leadless type. So this is what the pacemaker would look like in the individual. We can see that there is subcute there where it is fixed, and then you can see the leads going in to help pace the heart. So this is what I was trying to describe when we talked about the temporary pacing, when you do the transcutaneous type, where you place the pads. One is anterior posteriorly, one pad in the anterior surface, the posterior one at the back, and then you could do anterior lateral. That's the image is showing, how we'll put the parts, and then we'll pace. As we said, these are things you do in the emergency setting or pending when you want to do a permanent, insert a permanent pacemaker. So there are different recommendations for doing this, considering temporary pacing for patients with diagnosed node dysfunction. We've already talked about that they should be hemodynamically unstable, before we talk about passing a temporary pacing, Then also, we talked about when we shouldn't at all put a pacing, we shouldn't put do any form of pacing, even though there's bradycardia, is in patients with sinus node dysfunction with minimal or infrequent symptoms. So if the person is without hemodynamic compromise, we said it, no symptoms at all, there's no need putting any pacemaker. Even if there's bradycardia, try and sort out what is going on, especially when there's no AV block in this setting. Then other scenarios where you shouldn't is when the patient is asymptomatic, patient is having asymptomatic, where a patient is having asymptomatic bradycardia. So we've said this over and over. If the patient is asymptomatic, even when the pulse is low, it's sinus bradycardia, there's no symptoms, there's no need, because rather it might even, there's no need for putting the pacemaker. Then if, when you do your ulcer, you find that most often this bradycardia is at night, not even is at night, that's the only time you're picking it, there's still no need for it. Rather it said that you should just evaluate the person for obstructive sleep apnea and all of that. So another recommendation given by the American College of Cardiology is when there's the patient presented with symptomatic sinus node dysfunction secondary to a reversible cause. So there's a reversible cause, but at that point in time, we just want to pace the heart temporarily, pending when you reverse whatever is causing the issue. So you need a temporary pacemaker at that point in time. So other recommendations we have by the American College of Cardiology, it's patients, when you want to do a permanent one, we've talked about symptomatic sinus bradycardia. We've said it over and over, symptomatic sinus bradycardia is very important. Those that present with tachybrady syndrome, that's a sinus node dysfunction, it's important you consider putting a pacemaker at that point in time. Those that have symptomatic chronotropic incompetence, so meaning that with when they exert themselves, their heart rate doesn't increase as it should, because normally once there's some form of exertion, if you do any form of exercise, your heart rate should increase to keep up with the demands of the body. But in some of them, they are unable to mount up that response. So you should consider a pacemaker too for them. Other recommendations we talked about in patients with symptoms that are directly attributed to the sinus node dysfunction. So yes, there's a problem with sinus node dysfunction, so you need a pacemaker. That is a class 1 recommendation. So all these other recommendations, we would have the slides, we can go through them, they're quite detailed, just telling us when to and when is of no benefits, Then other recommendations to consider is when you have a second degree or third degree AV block. We've mentioned that already. The second degree AV block has to be a Morbis type 2, because we said that Morbis type 2 will later on graduate in, can become a complete heart block in the long run. So when you shouldn't, we talked about first degree AV block. There's no need for a pacemaker when you see the first degree AV block. Rather correct anything that you think might be a trigger. Correct whatever you think is a cause, or just monitor the patient if you can't find any etiology. There is no need for, except if it's symptomatic. And even when it's symptomatic, they say just consider. It's not like you must, but consider depending on other things you're looking at in the patient. Then other reasons why you shouldn't, we talked about acute AV block in a setting of where it's a reversible cause. We've talked about that. So basically, what have we said so far? We're talking about how to recognize bradycardia on ECG. We need to recognize these things on ECG, know our ECG well, and be able to recognize sinus bradycardia, tachybrady syndrome, sinus arrest, all those things. AV conduction abnormalities. Because when we are able to identify them, we can now tell who needs what. If they are asymptomatic, we already said there's no need for any medication or pacing, but except if the person has, we talked about the morbus type 2 or third degree AV block. And then we said if they are hemodynamically unstable, we should just follow the algorithm we talked about. Do your ABC of resuscitation when they come into the emergency. There's room for IV atropine. If it's not yielding any improvement in the pulse, there's room for dopamine, epinephrine, and then you can do a temporary pacing pending when you can now put a permanent, or you sort out the reversible course depending on what's going on. Talked about, hello? Okay. We have Dr. Iseko online. I don't know if you can hear us.
Yes, I can hear you. Please go on. Please go on. I'll join you. Go on. I think good.
Okay,
I'll
sir.
join. Once you are done, I'll just take a few slides.
Okay. So so basically we've talked about identifying these patients. So it's not just all about they have a low pulse. It's important we're able to pick symptoms because that will guide us on what we need to do next. And then what type of reading do they have? You know, if it is the AV conduction issue, is sinus node dysfunction, because we said majorly that the problem is either from the SA node or from the AV node that is preventing conduction down the pathway. So it's important we're able to pick all of that.
And also the etiology too,
yes,
possible causes. We talked about myriad of causes of bradycardia, electrolyte derangements, overlooked. We talked about endocrine causes like hypothyroidism. We talked about coronary and artery diseases. There are some patients with coronary artery disease, especially the ones affecting the right coronary arteries too, could possibly cause bradycardia. So these are things that we should always look out for, because the symptoms are very, very quite important in guiding us. And when we're investigating, aside from doing our resting ECG and water ECG, we should also do those ancillary investigations like our electrolytes, our thyroid.
And we can easily do those things,
yes,
you know,
yeah, things that we do
but we need to note that we should do these things because they might just be the cause of the bradycardia. Thyroid function, we need to do these things. These are things we do. I'm sure in every hospital they get.
And once you can identify them,
you now know when to refer, because if you don't have the facility for putting a temporary pacemaker or a permanent pacemaker, as soon as you are able to resuscitate, stabilize the patient, at least atropine is readily available, we can then refer to a appropriate facility where the device can be done. And we do this regularly. We see cases like this frequently. So in summary, the evaluation of patient bradycardia requires comprehensive history and physical as well as an ECG, as we've said. And in patients with sinus node dysfunction, asymptomatic patients have benign cause. So we just monitor those ones. You know, whereas symptomatic ones without a reversible cause, we said we need a pacemaker. Then in patients with AV block conduction disorders, we need to figure out which type do they have so as to know what to do for them. Either they will need a pacemaker or we just need to monitor them, and always check out for causes so that if they are reversible, we can address them. Thank you. So do we have, go back. This is summary. So do you have questions?
All right, so let me just make a few comments. Thank you very much for your fantastic presentation. I'm talking to you from Nairobi, Kenya, where I'm attending a conference at PASCA. So unfortunately, I'm not there physically, but thank God for technology. So I'm here with you virtually. So I will just, if you can allow me to share my screen, Pamela. Allow me to share my screen. I will just run through a few things that I just want to stress. I just want us to keep in mind as we are going, and we don't forget. Stop, if you can stop sharing now. Pamela, allow me to share my screen. Hello, can you allow me to share my screen, please?
Yes, sir. You can share now, sir.
No, it says host has disabled screen sharing. Can you click on it and then do what's necessary?
Okay.
All right, thank you all participants for joining us. We've looked at bradycardia. Bradycardia is a very important topic. Every doctor, every nurse, every healthcare worker must be exactly sure about bradycardia and what to do when they are faced with bradycardia. And so it may be in labor room, it may be in a different setup, but wherever you find bradycardia, you should know exactly what to do. You could see a patient, you could just be doing vital signs, you could be doing a CS for a patient, an emergency, and then find patient's pulse with 40 or something like that. And that is quite important to note. So I'll just run through briefly. So based on what has been said so far, number one, check the heart rate. Typically, yes, technically bradycardia is less than 60 per minute, but we begin to worry when less than 55, less than 50 per minute. So heart rate less than 50 per minute, we begin to worry. You have the history, like has been said already. Look at the symptoms. Are there symptoms related to the bradycardia? Is patient on drugs? And I want to emphasize eye drops. Sometimes patients are on eye drops for glaucoma and raised ocular pressure, and that in itself, timolol, eye drops, and the other kind of eye drops, and those could also cause bradycardia. Remember to check that. Look for history that could signify thyroid disorders, that could signify syncope, that could signify heart failure and other problems. So those are things that you should check out. So then, of course, you go on to examination. So you go on to examination. So on the examination, you will typically check the pulse and check for comorbidities. And on the pulse and comorbidities, what you are looking out for on examination, first of all, is this an emergency or not? All the cases we see with bradycardia are essentially those that are in clinic. They come in, there's no emergency, we just find their pulse to be incidentally low. What do you do for those patients? Those are the ones we go through everything that we said. However, if there are signs of instability, patient has an altered sensorium, there is hypotension, there's ischemic chest discomfort, there's acute heart failure, then immediately you go to the bradycardia with pulse algorithm. For those of you that were at our Abuja Cardiologist Symposium, you will have that algorithm in your book. So if you have not thrown away that book, you will see it on your book. For others, we'll try and send that algorithm along with the slides of this presentation, so that you can have it printed in your emergency room. But once you see somebody with bradycardia, coming up, and they have these symptoms, you need to treat that bradycardia, otherwise it will quickly become fatal. Now, do an ECG, and in the ECG, you are looking at the type of bradycardia you are looking at. Is it a sinus bradycardia? Check the rates to see how severe it is. Check the type of AV block that is there. And if you stick around when we are doing, you go to our web page, you will see the ECG interpretation. Please go through that video. That video will teach you how to read an ECG. So we took some time to explain this AV block, and it's very important in this context. So you need to look at the AV block, then you look at the QRS duration. Why is the QRS duration important? QRS duration of the ECG is important because it helps to tell us at what level is the bradycardia occurring in the heart. Is the bradycardia occurring at the level of the AV node, or is occurring below the AV node? So that is what we are seeing. Okay, so you check that. ECG, look at the QRS duration. Also look for a STEMI. patients could very easily have had a myocardial infarction, and the bradycardia you are seeing could be a complication of myocardial infarction. So don't just look and say the heart rate is 25 or 30. We've seen a patient before with heart rate of 19. And don't just look that the heart rate is 25 or 30. Look at the other parts of the ECG. Okay, look at the other parts of the ECG. Look for a STEMI. Is this patient having a myocardial infarction? Are there other things? Are there other things that are important there on that ECG? So those are the things you should be looking out for. Also look at the thyroid function tests. And they are important to look at. Thyroxine could be high, T3, T4 could be low, and this is important as a reversible cause of bradycardia. You don't really want to go and put in a pacemaker for somebody who has hypothyroidism that you could have treated. You want to look at the drugs the patient is on, and you want to be able to adjust those things. Now also do a cardiovascular profile, do echo, and if you can do drug toxicity studies, it will also be very important to do. Now, we've also talked about that. So we've talked about these 5 things. Number 1, check your heart rate. Number 2, take a good history immediately. Number 3, go on examination. An examination, the first thing you're looking at is any sign of instability. If there is none, then you can continue, do your ECG. On your ECG, check the rate, check for the type of AV block, check the carrier duration, check if there's an MI or other things. Then do your thyroid function test, do your cardiovascular profile. What do we mean by cardiovascular profile? Keep it, UCR, HbA1c, random blood sugar, uric acid, look for those things. You may want to do an echo, which could help tell you if there is a structural heart disease. Is this person already having a significant heart disease that you don't know? So sometimes there's a patient we saw, a 35-year-old man, AF was 20%. It was totally asymptomatic. So it was now this bradycardia that brought him to the hospital. Somebody now referred for bradycardia. So when we did the echo, we could now see these problems that were there. And are there any drugs that you are on? Then you can go on to a stress or holter if you are indeterminate. The holter can be done in cardio care. You can ask for patients to come around. We will attach the ECG to them for 24 or 48-hour period. During this time, there are major things we're checking. Are there prolonged pauses? Are there times when the heart actually stops for prolonged periods of time? Typically, we do RR interval greater than 2,000 milliseconds. Anytime that is more than 2,000 milliseconds, the ECG will record that. Then we also check anytime the patient has a symptom, they have to mark it, write it in their Holter diary so that we can correlate the time frame, and also they can press. There's a button on the Holter machine that they can press. That will help us check whether it happened around the same time. Then we can do exercise ECG where we are checking for chronologic incompetence. This is just a big word. A chronologic incompetence on exercise ECG simply means when the patient starts exercising, is their heart rate going up at the same rate of the exercise? As they are increasing the rate of exercise, the speed of the treadmill, or raising the inclination of the treadmill, is their heart rate going up? If their heart rate is not going up accordingly, then we know that there's a problem and that we'll likely have to intervene. Number 7, please refer to a specialist. You don't want to be saying you are managing a patient for bradycardia chronically without any specialist input at all. You have a specialist input, we practically will see and send back to you if it's a benign case, and if it's not. So you don't want the patient to die in your hand if you are not sure what you are doing. But you can, if you're on the WhatsApp group, which will show you how to join, you can easily ask a question on the group, and any of our 5 or 6 cardiologists will be able to answer any of the questions. Then number 8, treatment that we talked about. Address reversible causes and check. Observe and wait. If they are asymptomatic and hemodynamically stable, they have no structural heart disease and no issues. But when you're observing and wait, please make sure you have specialist input so that you don't keep a patient that should have had treatment and the patient dies or comes back as an emergency. Treat as an emergency with our bradycardia algorithm. If the patient is hemodynamically unstable, that is, hemodynamically unstable means that they are hypotensive, their pulse is very low, they have altered sensorium, they have some ischemic chest pain, or they have heart failure. You need to treat them as an emergency. And then in that emergency state, typically you can give atropine, but in some cases, atropine will not work, especially the TRS duration is prolonged. In that case, you need to put a temporary pacemaker while transferring them to a center that can put a permanent pacemaker like Cardiocare. So what can you do? They will show you a small video. They will show you our defibrillator, which you should try and have in your center. If you don't have, please, and you want to get guidance, also reach out to us on the WhatsApp group for the medical symposia, and we can direct you on which type is the best to purchase. Or maybe you can give me a contract if you're a government person. I'm looking. All right. So get the pacemaker, and for the pacemaker, simply what we do is to put the pads on the front and on the back. Typically, put it there and then, but it's quite discomforting because it's like shocking the patient. So you may want to do a transcutaneous pacemaker, or we do a transvenous pacemaker. Very easy to do, either through the jugular or through the femoral. Typically, we use femoral. We pass up a temporary pacemaker to the RV, and then we put on the machine, and that's all. Very simple. Anybody can do this. Once you can do a femoral cannulation, you can put a temporary transvenous pacemaker. And then when indicated, you should get a permanent pacemaker. Those are the 8 things. So again, heart rate, history, examination, ECG, do your test, TFT, cardiovascular profile. You must do an ECG. You must do an ECG. Don't manage any patient and say that the heart rate is 50. Don't worry, it's not bad enough. No, you must do an ECG because there could be very critical things. It's possible for the patient to have a complete AV block and the heart rate is only 50. They probably will still need to have a pacemaker in a lot of cases, even though their heart rate has not gone down so much. So then consider stress or Holter ECG, get specialist input, and then these are the treatments. Now, most often, symptomatic bradycardia is as a result of, it's an indication for permanent pacing if there are no treatment alternatives. And most of the cases are due to sinus node dysfunction and AV block. So think about sinus node dysfunction and AV block. So how do we choose the pacemaker that we use? We either do a dual chamber, we could do a single chamber pacemaker, or we could do a cardiac resynchronization therapy with pacemaker, with pacing. So if a patient has a 2nd or 3rd degree AV block, or we think that they could have an AV block now or in the future, we put a dual chamber pacemaker. That is typically it. So most patients put a dual chamber pacemaker. Typical patients where we put a single chamber pacemaker are those with chronic AF. That is, the atrium is beating very irregularly. And you can, even if you put a lead in the right atrium and the right ventricle, there will be no, having that AV synchrony may not still be able to be attained. So in those cases, a single chamber may suffice. Now, if patient has heart failure, QRS is prolonged, and they are now having a block or they are having bradycardia, then in that case, you don't want to just put a pacemaker. You want to put a CRTP or CRTD for those patients. So in those kind of cases, we put a CRT. What's a CRT? In a CRT, we don't only put the leads in the right atrium and the right ventricle. We also put a lead to kind of stimulate the left ventricle, but we'll do that lead through the coronary sinus. So it's like trying to place the left ventricle, right ventricle, and right atrium so that you improve patient function. So if you look at this this image in front of you, you can see, and if you can see my mouse, you can see how we put it. There's one in the right atrium, there's one in the right ventricle. Then we take one through the coronary sinus to stimulate the left ventricle. This is what the CRT looks like. It's quite expensive, so it's reserved for those that are in heart failure. You know, their EF is less than 35%, their QRS is prolonged, and they need a pacemaker. Then instead of putting just a dual chamber pacemaker, which will worsen the heart failure, you may want to put in a CRT in addition to, instead of just a dual chamber pacemaker. So look at the QRS. If the QRS is more than 130 or QRS more than 150, then you should consider very strongly putting in a CRT instead of a basic pacemaker. Okay, so now this is another simple table to tell you whether to put CRT or ICD, and it's looking at the NYHA class and the QRS interval. By the time patients are getting to NYHA 2 or 3 and the QRS interval is prolonged, we put in a CRT. If it is a CRT that needs a pacemaker, then we put in a CRTP. Or otherwise, we put a CRTD. But remember that the TRTD can also pace in most cases. So this is something to do. This is what the procedure looks like. We do it while awake. First thing, patient is lying down. We anesthetize this area, you know, as you are seeing in the video. Then after anesthetizing, we take a small incision and simply at the axillary vein or the extrathoracic subclavian, which will insert we puncture the subclavian vein, and then through there we pass our lead straight down into the right atrium there and the right ventricle. Typically, we put the right ventricle first. And the reason is that if the patient goes asystolic or the bradycardia becomes very bad on the table, we want to have a lead in that we can start pacing immediately. In some cases, we put a temporary pacemaker while we are doing this procedure. They'll put the right ventricle, then we'll put the right atrium. So that's essentially what is done. We've done quite a number over a long time. This is an old data presented last year or so. And if you want to refer, just give a standard referral letter, attach available results. If it's an emergency, you want to call us as well, so that we can give you directions on temporary pacing while you are moving the patient, so that you don't lose the patient in transit. Okay, and then so you can call any of the numbers or WhatsApp these numbers. And so Cardiocare is in Abuja. We've won several awards. We've been focused essentially on cardiovascular medicine, and I'm very happy to be here, and I'm happy that you have joined us today for this wonderful and very topical thing. So Dr. Inuwa is going to show us the defibrillator. If you look on, so I will just stop sharing now so that you can see her video. So Dr. Inuwa, you can show your video. Unmute yourself so that you can show. So typically on that video, as you are seeing Dr. Inuwa on her video, on that video, you simply get your defibrillator, which is something like this. A lot of hospitals have it, but don't know how to use it very well. You simply get your defibrillator. So if you can click on her video so that you can see her very well, you will turn the dial till it's so. Camera, can you focus on the video on the device, please?
You have to bring it down.
Just focus on the device. So once you put it on, you will turn the dial till it reaches spacer. Once it reaches spacer, you will stick the pads, typically one on the front and one at the back. Typically when you want to pace. So you take the pad, you stick one in the front and one on the back. Or you could do this the standard one for standard defibrillation, which is one under the right clavicle and one at the apex of the heart, that is just below the nipple on the left. So you could do that, or you could do it the other way around. Okay. Now remember that this kind of transcutaneous pacing is possible in your facility. You can use it and move a patient from one facility to the other. You can do it. It's not difficult. And then you press pace. But it is very uncomfortable. So typically you have to give some diazepam. You need to give some slight sedation, because it is like shocking the patient, and each heartbeat is now controlled by a shock fluid. So if it's for very unstable patients that have not responded to atropine, they have not responded to dopamine or phenylephrine, and and they are quite unstable, their heart is going down, you need to move them. You need to start this one while moving. So try and make sure that you have one of these in your facility, because the time you will need it, it will absolutely be life-saving. Camera, can you focus? You're not focusing. Focus this thing. Dr. Inuwa, can you show this thing? Good. So just look at that video, that picture. This is in Cardiocare. This is one of our many defibrillators that we use in our theater, and it's life-saving. Beautiful. So you see number one there, you simply turn number one to pacing. Once you turn number one to pacing, yeah, it's on pacing, Abby. So once you turn it to pacing, you stick the pads and then you click to start pacing, and that is just about it. You can do that while calling me or calling any PCI capable lab that can now put in a permanent pacemaker or give definitive treatment, or while you are transferring to a center. Thank you. Dr. Inuwa, do you have anything to add?
No, sir, you said it all. Thank you, sir.
There are some questions in the chat box. Somebody says they want to join the group chats. Pamela, can you put up the QR code or something so that people can easily join the group chat? Another person says, thank you. Thank you, Dr. Tony Uzo, for thanking us. And somebody said bradycardia due to hypothermia, moderate to severe, are often refractory to atropine or ACLS protocol. Why? Dr. Inuwa, can you?
Hello, can you hear me? Oh,
yes, we can.
Okay. With hypothermia, it's not a vagally mediated response, so the atropine wouldn't might not be of any might not have any impact. So that is why once there's hypothermia, we're not thinking of IV atropine, might not see much effect because it's not vagally mediated. The hypothermia is not vagally mediated, so you might not see any benefits. So rather, you can do other things like the dopamine we mentioned, and then the adrenaline and the epinephrine, and then temporary pacing, and then subsequently there's a need permanent.
Okay, you can open the other picture, the other what they call it, the other question.
The other question was what would be the appropriate approach to bradycardia in pregnant women? Well, same thing, no difference whether she's pregnant or not. Same response. We need to keep the woman alive as much as also the baby, but we also need to keep the woman alive. So at that point in time, we still need to do all that we should do. The resuscitation, as we said, in the ACLS, and do every other thing like we mentioned. There's no difference whether she's pregnant or not. Then there's another question on, in cases where access to a referral center is not immediate, how long can the effect of therapy with IV atropine, for example, last? Well, based on the algorithm, we've mentioned that you start with 1 milligram, 3 to 5 minutes, and then the max is 3 milligram. Then you start with either your temporary pacing, or that's your transcutaneous, or you do your dopamine, or you do your adrenaline, and then you can then refer. So all of that will keep the patient on pending when you can refer. So your dopamine, once you're done exhausting the max of your atropine, you can continue with your dopamine or epinephrine or alongside, and then refer.
Next one is, you throw more light on the atropine use in the emergency setting?
Okay, the atropine use in emergency setting, we've said, first of all, ABC of resuscitation. You want to ensure that you, the patient is breathing well, there's good oxygen saturation, airway is patent, we need to do all of that. And then IV atropine, we said 1 milligram, 3 to 5 minutes, max 3 milligram, no response. If there's response, good. While we are still sorting out reversible causes or planning for, or then you do your ECGs because you need to know the rhythm, to know what to do, whether it's temporary pacing or permanent, depending on what you're faced with. And then if you've maxed out your atropine, you can then move on to dopamine or your epinephrine. And then refer if you don't have the facility for the pacemaker at this point. I think that's all. That's all.
Okay, there's a question that said if you don't have access to a, somebody said in cases where access to a referral center is not immediate. Okay, that's how long can that last? So I will just show you the algorithm again so that you can see. If you see, you can see after the atropine first dose, you repeat every 3 to 5 minutes, maximum 3 milligrams. So don't give more than 3 doses. Then the dopamine infusion. Okay, you can start your dopamine infusion while you start trying to make necessary arrangements. You can also give a call so that you can get, online support from a cardiologist nearby or far away. Remember, these days we have WhatsApp, we have so many things that we can use to assist. So either cardio care or any cardiologist in your vicinity to be able to help you pending well. Now we've also showed you how to use your transcutaneous pacing with that device. If you have one in your hospital or any hospital near you, you can use that as well. You can also get to a center that has a normal CR to be able to put in a transvenous temporary pacing if they can. So you can see persistent bradyarrhythmia, you can continue that. You can also add or start epinephrine infusion, okay, while you are trying to do your transfer. So those are some things that you can do. so transcutaneous pacing plus dopamine or epinephrine infusion, adrenaline infusion, and then transvenous pacing or expert consultation. So those are some things that you can do in that regard. Okay, so Dr. Kibuke Ozo, I hope that answers your question on tremor, light, or neutropenia used in emergency settings. So not more than 3 doses, give once, twice, 3 times. Look at the QRS complex, get a 12-minute ECG as well, get specialist input. You may remember that the ones that have wider QRS are typically less likely to respond. Now, if you are registered and you register with your email, somebody say, can I get an e-copy of the presentation? Yes, if you register with your email, you will get, over the next few days, you will get an email with the presentation. You will also get a link to our YouTube page. And if you go to our YouTube page in a few days, you can rewatch this presentation. You can present it in your hospital. If you get the slides also, you can share it widely with your people. Just give us credit, and you know, that would be quite helpful. Okay, I don't know if there are any other questions. Any burning questions, you can raise your hand. If there are any burning questions. Okay, if there are no burning questions, I will just show something about cardio care a little bit. I don't know if you can see my screen very well. And you know, this cardio care, we're talking to you from Abuja. Actually, I'm away in Nairobi, at the conference where we're presenting our work to Africa. Cardio care is part of the Limi Hospital Group, founded in 1982, and we are over 41 years in. And you know, one of the key things is about being able to give local research, give exposure, and help our people. Not everybody can travel abroad. So amongst us here, there are patients that need this care. It can be done safely, regularly here in Nigeria. We've had multiple awards by the grace of God. We have 2 interventional cardiologists, 4 clinical cardiologists. We're taking residents from UPTH, OETH, University of Gabalada, you know, University of Abuja Teaching Hospital, all coming in. We do several symposia, and I want to encourage our participants. Plan to be at this year's annual Abuja Cardiovascular Symposium, the 7th one. It will be fantastic. Plan to be here. It's typically the first week of December. 10 TME points, 2 days course, fantastic reading ECG. All of these things we'll handle them in detail. You can meet all the different members of the cardio care faculty, discuss your cases, and so try and be there for the 6th Abuja Cardiovascular Symposium. And if you're a cardiologist, plan to be around for the 2nd Interventional Cardiology Symposium. Okay, so it's very important. And you can join our webinar. This is one of the Abuja Cardiovascular Symposium. You can see how full it is, how rich it is. We typically have over 350 participants from 17 states. We'll focus on BLS or ACLS. We will show you what to do in these kind of situations. We will teach you how to read an ECG and answer your questions. So go online, watch our videos, but also try and make an attempt to attend this. If you plan for it now, you'll be able to attend this. And at the last Interventional Cardiology Symposium, this were a lot of cardiologists coming from all over the country. Yeah, so we've done quite a number of procedures. This is a coronary angiogram, and as you can see, it's very simple. It's something that you can do. I'm sure. I'm joking. You can't do it. But in the cath lab, we place femoral puncture. We put a needle into the femoral artery, and then pass it wire. The patient is awake completely, no scars, and then we pass our wire in, just like this schematic diagram is showing. And once we are putting the sheet into the femoral artery, we also use the radial artery sometimes so that it's also check and go home faster. And after we've done that, we've done over quite a number. These are old numbers from 1 or 2 years ago. And then once we do that, we do the angio. I'm sure you can easily see the, I don't know if everybody can see that. I'm sure you can easily see the place where there's a blockage. Can we see that? I've tried to mark it a bit. So that is the area where there's a blockage. I think we can see that arrow. We can see this other part of the vessel looking okay, and then this place looking narrow. This was a 40-something-year-old patient that came with chest pain, and then we did an angiogram immediately, and you can see the area of narrowing. And of course, we'll go on to stent such immediately. So you can see that area of narrowing. And then what we do at the same sitting, typically within 1 hour, 1.5 hours, we are done. We pass a wire across that narrowed lesion. Okay, so we pass a wire across that narrowed lesion using special techniques. After the wire is passed, we put a balloon to open up the area a little bit. But that is not enough. Balloon angioplasty will recur. So after that, we now pass in our stents. Okay, our stents are all drug-eluting stents. Okay, so latest drug-eluting stents. Typically, they are coated with everolimus, and it stays there for life. Fantastic. And then we can do this. Is how we inflate the stent. It's not with a syringe. We use this special device called an inflation device. That inflation device helps us to you can see the stent there. You can see the stent there being inflated using that inflation device. So that inflation device helps us to make sure that we put in the stent at the exact pressure that is needed. Okay, so that we don't put the pressure above. Typically 10, 12 atmospheres of pressure. And then once we are done, we check. Patient is awake, we're talking to the patient, and you can see that narrowing is disappeared in this case. So this is typically what we've done, close to 400 now, number of cases here in Abuja. And so patients do not necessarily have to go abroad. Okay, similar procedure is done for, so if you have patients with chest pain, patients with acute and coronary syndrome or chronic having angina when they have exercise, they have heart failure, they have abnormal CT, they have abnormal ECG, we typically will consider doing that, So then pacemakers, we talk about pacemakers, cardiac resuscitation therapies. As at last year, we had done about 40-something, but as of now, we've done close to 80 or 100, the number, and it's been very fantastic work here in Nigeria. And we talked about this when we were talking earlier. Now, I want you to look at this video. This is what the CRT looks like for this video. You can see you have this lead you are looking at with that small screw you are looking at there is the, look at you can see my cursor. That's the right atrial lead in the right atrium, Then that is the battery or the can. And then if you look at this lead we are looking at here, that you can see this lead coming down like this. This is a bipolar LV lead. It is actually in the coronary sinus and wrapping around the left ventricle. And this typically improves clinical, patient with heart failure. When you have advanced heart failure, they get very fantastic results. They are very happy with you. Now you will see there's another lead here that is going to the right ventricle. Now the difference between this and an ordinary pacemaker, if you look at the lead, you will see that the lead has this thick area. This thick area is the ICD coil. This is what can shock the heart if the heart develops an abnormal rhythm. So the ICD or the CRT can pace as well. But if the heart develops an abnormal rhythm like a VT, a ventricular fibrillation, it will pick it up immediately and it can deliver this shock. So it has this coil here and this coil. Nowadays, we don't like to use the ones that have 2 coils anymore, because if we have to remove it, it can become very difficult. So of recent, we had to change most of our leads for the new patients that we're putting into ones that have a single coil because of studies that have come out recently. So those are the things that So this is what the CRT looks like, and this was done right here in Abuja. So our patients don't have to travel far and wide and spend huge amounts of money. This device on the left is used to interrogate, check the pacemaker, check whether it's working well, check the CRT, check whether it's working well. Okay. Now, if you look at this patient, this is a single chamber ICD. Like I told you, difference between a pacemaker and ICD, you can see this thick shocking coil there. Normally, if it's a pacemaker, it will all be thin like this, but it's an ICD to have this thick sleeve over it. Now, if you look at this patient, you can see he was having relatively normal rhythm, and then he started having a VT. By this time, he went unconscious, and within a few seconds, we're able to give a shock, an external shock, and then we now have to put in this. So you can see that this device actually saved life. This patient would have gone, okay, if the patient did not have that. So We've also done quite a number of peripheral angioplasties. And you can see this is anterior tibial artery. And you can see the blockage. There's a complete blockage there. And so you can see there's a complete blockage right there that has stopped blood flow and that was causing the limb to go dark. So this is how we inflate. Now we are putting our stents in. We put our stents in there. After we put our stents in, using the same way we do for the coronary, and you can see the blood flow restored back to that anterior tibial. This is the tibial tuberosity. This has helped to reduce gangrene. You can see the before and the after pictures. Before, you have had to just cut off this leg after a while, but now you can reduce the number of patients that need amputation. So that's quite important that we can do as individuals. So if you have patients with critical limb ischemia, especially those with diabetes, they have non-healing ulcers, do their peripheral Dopplers, check their pulses, do their ankle brachial index, and if they need, we could easily be of help in that regard. So this is essentially similar, showing how it is done. Okay. This is this is a renal angiogram being done. In this case, we had a patient come in with acute abdomen with complete occlusion of the renal artery, 100% occlusion, severe pain. Luckily, he was in a good center where they could do an urgent CT abdomen, and they did a CT angio as well when they could not see anything on the plain CT. And they realized that there was no flow on there. So they sent urgently, came from another state, had to start driving down. And then when he came in, we took him straight to the cath lab, did the angiogram, and you can see on this side, before we proceeded, there was no flow, 100% occlusion. And after that, what we did here was to do a catheter-directed thrombolytic therapy. We put in a catheter here, we macerated the clot, tried to shift out the clot, and then slowly infiltrated thrombolytics there, and restored blood flow, and was able to discharge 2 days later with good outcome. This is a case with a pulmonary embolus. And you can see this is our catheter. This side should have had this left pulmonary, and this big clot was there. The patient was sent to us, and we did a similar thing. And you can see after we have done that, you can see the blood flow in that area for where there was absolutely no blood flow. So this has a very good implication in terms of patients' long-term prognosis for that. So there are quite a number of cases that we've done, IVC filter, removal. I also want to show you this case. Patient came in with iatrogenic injury. PCV was 12%. And if you look at the video clearly, you can see where the blood supply, where the artery was injured while they were trying to place a femoral catheter before they referred. Now the patient refused blood. PCV was 12%. So there was limited option for intervention. So we went in, located the area that was bleeding, okay? And then after locating the area that was bleeding, we put in the stent. You can see the stent being placed. We have to take our time to meticulously position it. And after doing that, you can see this before. After doing that, you can see. So you can see this is before, and this is after. So we've covered that stent. Patient at 12%, and we're able to discharge back and refer back to the referring center. This is cardio care hospital, in case you have never been to cardio care before. So then IVC, we put IVCs and remove them. And this is a very interesting case. This is a case of, you can see this opacity here. This is a catheter, a neckline that was put in a tertiary hospital in Nigeria. And what happened was that while they were trying to remove it, after they had finished using it, the line broke and moved into the heart. So the patient was sent in order to avoid surgery and to avoid going abroad for us to try and remove this the same day. And we're able to do that without having to open up the patient. And you can see our catheter coming from down. You can see the thing that was broken in the right atrium. And what we did was to go from down and improvise with a hook and create that and pull down that foreign body in the heart. So very interesting case. We've since published this case in international journals, and you can see we're able to pull it down. pull it down and able to lasso it inside the heart and bring it out successfully. Patient went home the next day, same day, no complications thereafter. So we brought it out and I will show you, look at what was inside the right atrium dancing around. And the patient went home, so 27 centimeters was the length of this catheter that broke into the heart. And quite important, we give the patient as a souvenir to take home. And you know, this prevented cardiac surgery. So again, I've told you about cardiac care and all of that. And we'll be happy to receive your cases. We'll be happy to discuss cases. We'll be happy to have you over, especially if you're a cardiologist. Come over and join us in the cath lab. We'll be happy to have you. You know, not just in cardiology, but in other fields. This is what the hospital looks like. In neurology, in endocrinology, in critical care, stroke, and it's complex. And we are starting open heart surgery this month. So if you have cases that need open heart surgery, you can refer them. Let's start preparing them for the batch. We did our first renal transplant last week, and we hope to do more great things while working with you. So thank you very much for joining us. If there are any final questions, I will take them briefly. And Dr. Inuwa, there's a question from my very good friend, Dr. Cardiologist. So how do you manage morphine-induced or opioid-induced bradycardia? Dr. Cardiologist, nice to read from you. Long time, good to hear from you, Dr. Akido.
Hello, can you hear me? Okay. Oh, okay. We use naloxone. We can use naloxone for it, and then we also would go through the same ACLS as we said. It's always very important to go through the basics, and then alongside while we are correcting, then we can once we know that it's opioid-induced, morphine-induced, then we can give them the antidote, and then while we still continue with our atropine, as we said, give no response, dopamine or epinephrine, while we're waiting for the reversal to take place, while we're still monitoring the patients on ECG. If there's a need, we'll just that cases like that, patients will need a temporary pacemaker because we know that once the reversal occurs, everything returns back to normal, and then the person will not need the pacemaker anymore. Does that answer the question? What else? Sorry, what's that?
To you, Dr. Inuwa. I think you can complete the case. Please, if you have any questions, let us know. What's the antidote for opioid induced? I think Doctor, he said she's said already naloxone typically. There are other things that have been discussed along opioids, and sometimes you need to remember that some of these patients may not respond initially, or may have prolonged bradycardia despite treatment. In those cases, you still follow the same algorithm. Sometimes you have to put in a temporary pacemaker while waiting for whatever dose of drug, it could be morphine or something else, to wear off if you don't get that quick response. Okay, so those are some of the things that are typically done in that regard. But be very careful, so that you be sure. Look at the other things that could suggest the morphine induction, so that you know exactly what you are giving or dealing with. I don't know if there's any other question before we round up. Pamela, do you have the link so that they can join the WhatsApp group? Somebody has asked for the link to join the WhatsApp group. If you're in the WhatsApp group, you can ask questions, you can post your ECGs, we can answer them at any time. And then, of course, we can be of assistance to you in one way or the other. So remember, if you have your patient, I shared 8 points. You have a patient, do your history, do your examination, find the things, know what to do if it's an emergency, if there's none, know when the patient needs pacing, get input from specialists, You can refer to cardio care and can easily put in some of that. Okay. Don't know if there are any other questions. Okay, so if there are no other questions, I think we will conclude. Thank you very much for joining us. Once again, you could go to our website, cardiocare.ng, and you can find all our previous webinars so that you can watch them. You can go to YouTube and search for Cardio Care, and you will find plenty of webinars on different topics, including reading an ECG, which is critical for us. Make sure you try and do that. We'll be very happy to help in one way or the other. So go there, follow, subscribe, and then click notifications. When you subscribe and click notifications, you will easily get notifications whenever we have a new video that we have put on there. So those are the very important things for us to know. Next month again, we'll be here. We will send you emails and we'll send you WhatsApp. Please help us share. I'm sure you are getting getting benefit from this meeting. So invite your colleagues. If you look in the Q&A box, the chat link has been pasted, so you can just click on it and join the WhatsApp group. If you look at the Q&A box, you can just join it. So click on the Q&A, you will see the link. You can just join. Click on the group and join. Okay, we'll also try and send that link to you. And then at any time, just post your thing. But our rule in our group is this: when you post an ECG or you post a case, attempt to answer it. And then we also will now attempt thereafter. If it's an emergency, make sure you make a call because we're not always online 24/7. Thank you very much for joining us, and God bless you.